big sky, big potential. In association with Mills and Reeve, this is Eastern Promise. Achieving more together. Welcome to the East of England and to the podcast that heralds this region's brilliance around the world. And believe me, we've got a boatload of brilliance to share on this week's episode of Eastern Promise. I'm your host, Mike Rigby, and this week I'm at the home of Health Innovation East, one of 15 health innovation networks that support the introduction of innovative technologies to transform health and care. I'll be chatting with Chief Executive Piers Ricketts about how Health Innovation East is putting the multiplicity of fantastic new healthcare developments emerging from the East of England's researchers into practice. So join me as I ask Piers how our region's innovation arm of the NHS is leading the technological charge on this week's Eastern Promise. In recent decades, the day-to-day realities of healthcare have changed dramatically. The development of new care pathways, ever more focused research, and new medtech innovations have meant improved outcomes for patients across the UK and beyond. The NHS has introduced 15 health innovation networks across the country. One of those networks is, of course, Health Innovation East, which is an interdisciplinary team of clinicians, data scientists, life science industry experts, and skilled programme leaders. Together, their task is to bring the best innovations in health and care to the people, places, and problems where they can do the most good. And let's be clear, every part of our region has something to offer. Whether it's food as healthcare, telemedicine, medtech advances, novel drug discovery, or care pathway innovations. Shortly, you'll be learning why the East is one of, if not the most dynamic healthcare network available to the NHS. Small wonder then that I've been keen to get the Chief Executive of Health Innovation East, Piers Ricketts, onto this podcast to explain why. Great ideas only make a difference for our health when they are put into practice. So says the Impact Report 2024-2025 by Health Innovation East. And one of the principal authors, his signature is on, I think, the second page, is sitting with me now. Piers Ricketts, Chief Executive of Health Innovation East. Welcome to Eastern Promise. What a pleasure to have you with us today.
Thank you very much. I'm delighted to be here.
So give us a quick introduction to yourself and to Health Innovation East for those who may not know what it is you do.
So Health Innovation East first. So we are part of the Health Innovation Network, which effectively is the innovation arm of the NHS. We can talk a little bit more in a minute about that, what that means. But our core funding comes from NHS England and the Government's Office for Life Sciences. And the idea is that we support the adoption and spread of what we call late-stage innovations. So medicines, products, technologies, new ways of caring for people, which may well have had regulatory approval, but have not yet got into practice. So it's all about implementation. And again, I'm sure we'll come on to that a bit more in a minute. My own background has been pretty varied. I've been in and around healthcare for probably 20 years plus. I spent the majority of my professional career with KPMG, the big professional services firm, wound up running the firm's healthcare consulting practice, and then subsequently came to Health Innovation East at the time when we were called Eastern Academic Health Science Network. It's good that we've changed that name because it's a bit of a mouthful. I've been here for 7 years, in which time we've grown from 25 people to 80 plus that we are now.
Well, I mean, what a great time to be in this space. And you talk about implementation, and I noticed that the line at the very top of your forward in the impact review is implementing proven innovation. So, yeah, that's all the great ideas in the world matter not a jot if they don't actually get onto wards, get into pharmacies, get into GP surgeries, or even just on the shelf. So how do you do that? How does Health Innovation East make that leap, or help companies make that leap?
Well, I think you've alighted on absolutely the key reason why we're here and the key factor behind our success. So if you think about research and development, which is where innovation ultimately comes from, as a country, we are still one of the most generous funders of early stage scientific discovery research. The government puts a lot of money into it. Organisations like the Wellcome Trust and Wellcome Foundation put a lot of money into it. But all those innovations that might be discoveries in the lab, they might be algorithms written by teams using AI, whatever it is, they're not going to get to patients or to clinicians or to us as citizens unless they're put into practice. And this is all about implementation, as we've said. It's about change management. And change management, as my old boss used to say, is a human contact sport, and the currency is people, right?
That's a great way of describing it. I've never heard that before.
Yes.
Oh, my goodness.
Well, it's my old boss and mentor from a few years ago, who's a well-known sort of global health commentator and has led large NHS organisations. So it's about getting people to do things differently, and in particular it's about getting clinicians to do things differently, because there may be a new diagnostic test which rapidly reduces the time to diagnosis. It might be an implant, it might be an algorithm that enables patients and a platform that enables patients to manage their long-term condition with less formal intervention from the clinician than they might traditionally have had. But of course, doctors, nurses, health professionals are first and foremost licensed regulated professionals. And the research tells us that when you're looking at changing the working practices of regulated professionals who have done many, many years of training, their first duty is to their training and to their patients, and their duty to the institution and the reasons why they might need to change comes quite a long way down, and they're also quite busy. So we have a multidisciplinary team we have some qualified doctors, we have some ex-nurses, we have pharmacists, we have data scientists, and we have people who, like myself, have come more from a sort of change management and management type background. So we've got a multidisciplinary team because we recognise that if we write out to one of our local NHS hospitals and say, we think this thing is really good, here are the results, we think your guys should do it, they're not going to listen to because they're far too busy, but we actually need to provide them the evidence as to why they should do this new thing, and we can talk about that in a minute. But then we need to show them how they could do it with minimal intervention, or perhaps even quite significant change in how they currently look after patients, but how they can achieve that. So change management is always difficult, because you're asking people to do things differently from how they've done it, in some cases, for many years before. But change management in healthcare is particularly difficult because of clinicians and doctors' adherence, quite rightly, to their medical training and what they know and their own experience with their own patient cohorts, and the constraints of the institution they're working for, whether it's a hospital with lots of complex procedures or whether it's a GP surgery where these are essentially small businesses that don't have a lot of time to do different things.
That's really interesting, because that's really interesting because as you were saying that, this phrase kind of swum to the forefront of my brain, which was the tech. It sounds like the tech's the easy bit. Absolutely. The innovation is the easy part. It's in getting busy people. You bring in people to the team who can speak their language. You can say, I know, I understand the pressures upon you. We think we can help alleviate those a bit, and here is how. And here's all the data to show you that it's not just a flash in the pan. So you've not just got to have professionals, you've got to have, dare I say, sort of person professionals.
Absolutely, yeah. And so many of the people you use, with the biggest therapeutic area we've worked in over the years has been cardiovascular disease. Your listeners may well know that cardiovascular disease still remains the most preventable cause of early mortality. And the way we often do those programs is we work with cardiologists in particular, but also lipidologists, GPs in some cases with a special interest in cardiology, to go out to the clinical and medical community with us, often through online, to start with through online webinars and so on, to say, here's the science, here's why this is good, here's how you can change clinical practice, and show them different ways to do it. So we work with people whom the doctors and nurses and so on would trust, so with specialists in the relevant area. So that helps.
Absolutely. So just to shift it away from the medical profession a little bit, so what's the experience of being a partner with Health Innovation East, would you say, from the point of view of the innovator? Because a lot of people listening to this, I think, will either know or be themselves in the innovation space, be it tech, be it pharmaceutical processes, what have you.
I'm really proud of the feedback we constantly get from innovators. So we've started talking about the NHS, and we're improving healthcare for UK citizens and for how doctors, nurses and other clinicians deliver it. But the other side of this is the innovators who will come from a university spin-out potentially, or they'll come from the private sector, or indeed the third sector. And the remit of that side of our work is to help these people to position their products in a way that the NHS finds much easier to understand. So the key thing is, what is the evidence case for this? So not so much has the MHRA certified your medical device as safe as a Class 1 or a Class 2 device, for example. Not even so much, has NICE approved your medicine for a particular population cohort under certain conditions, which is what NICE does. But where is what we call the real-world evidence that your product, your technology, your medicine with a care pathway works with real clinicians in real care settings and with real patients? And there's a really interesting example. We've worked with a company called 52 North, who provide a very quick blood test for neutropenic sepsis for patients undergoing chemotherapy. So if you've got cancer and you're undergoing chemotherapy, many of our listeners will know, this reduces, makes your immune system much weaker, and you're therefore much more susceptible to infections. And typically, if you're a chemotherapy patient, I'm sort of perhaps over-summarising, but if you get a cold or an indication, even of a small respiratory infection like that, it was often off back into hospital to get checked out, because actually that could escalate very quickly if you've got reduced effective effects on the immune system. And in the worst case, that can deteriorate into sepsis, in particular form of sepsis called neutropenic sepsis. 52 North developed a blood test which patients can do at home. So it's a pinprick test, a little bit like the lateral flow test that we swap, but this is a pinprick one that we used to use. You put it in the cartridge, you turn it. And there's lots of really interesting things here. So they used patients. They had a patient group to help them with the design of it. Right. So if you think back to COVID, you're actually doing a pinprick blood test rather than a swab from your throat. But you're then putting the blood into a cartridge. You want to make sure it's gone in. Yeah. And what the patients wanted was like a clicking device that they could turn instead of just a small cartridge. So they knew that the reaction was then happening. Yeah. But then on the hospital, that was important. But in terms of the hospital side of things, this has a massive positive impact on flow, because typically if you had chemo patients, there would be a demand for certain numbers of patients who during the course of their treatment will be coming in often under emergency conditions, because then they'd have to be looked after. Whereas this test prevents that. But it may also mean that you've got to have, it rules out sepsis, but it might also mean that you've got to have a different conversation with your oncologist or with the treating team. So there's impact on, that's where the benefit is. So not just this is a quick blood test, but actually this blood test simplifies the pathway. Now 52 North's a great company. They didn't particularly help in doing that, but often when we work with innovators, it's think of the whole, what we call the care pathway. So if I'm being treated for a particular condition, particularly a long-term condition, what are all the different interventions with different clinical teams that I have to go through? If it's a long-term condition, I might not come out the other side, but actually how does it get managed at the different stages? And so it's not just the scientific discovery of the clever tests. that the innovator needs to write. If you're selling to the NHS, it's actually how does it make what we call the pathway different. And some innovators, like 52 North, get that pretty quickly. Others, work with us to understand that.
So, I mean, I know, for example, that you do a lot of work in health app development, and I would imagine from what you're saying that there may be some health app developers saying, well, you do this and you do your Face ID thing, and then it does that process, and then there you are. And that's it. It's really good, but you have to bear in mind the whole journey along the healthcare pathway, and your app is just a bit of it. So what happens either side? Is that so it's helping them get that broader view?
Exactly. One other example, I think, that's just come into my head, if it's okay, is a test that we worked on for preeclampsia. So preeclampsia, as your listeners will know, presents as very, very severe chest or abdominal pains in pregnant women, typically in the third trimester. Again, back in the day, 5 years, certainly 10 years ago, very, very serious. You turn up in A&E or in the maternity department, and potentially you could be hospitalised for the remaining 10 weeks of the term, because this was difficult to rule out. But if it's allowed to develop, has very, very severe consequences both for the mother and the developing baby. One of the big diagnostic test manufacturers developed a test to rule out preeclampsia. So imagine now you come into A&E, presuming that the A&E team and the maternity team know about this, presuming that your hospital has the right equipment in the pathology department, all the rest of it, you can have this test and it rules it out. So immediately, the number one cause of the particular array of symptoms is ruled out. So imagine the impact. You can then go home, or at least if, it might still be another problem that needs to be investigated, but the impact on families, but also if you think of the implementation work that requires in the hospital. So all your A&E teams need to know about it. Yeah. Your maternity team that needs to know about it. You've got to have the right kit in your path lab. You've got to have the analysers that can do the right assays for this, because not all of them can. Yeah. So it's all, again, that sort of implementation journey, which we have to help the innovators to understand. So patenting, or as it were, perfecting this test to start with is, as you say, just the first stage in the successful implementation journey.
So how much do you get into helping those companies that come to you, or you indeed do, if you go to them? I mean, do you, for example, you mentioned earlier about regulatory approval. Mm-hmm. Is that something you help with, or is that more? I mean, I want to come on to sort of the paid for part of what you do, which I think is really interesting. But so I'm just interested to see to what extent you sort of get into to helping them along the whole journey.
Yeah. Well, we get emails or phone calls. It certainly used to be about 10 a week from different innovators, because obviously we're privileged to be in Cambridge and the Greater East of England. It's a huge kind of hub of invention and innovation. And those will range from two-person startup, a couple of guys or girls have written an app that does something, all the way through to our biggest health tech and life sciences companies like AstraZeneca or Bayer, whoever it is that we work with. And it's that whole kind of gamut. And essentially our offer, this is under our core funding from the Office for Life Sciences, our offer fits into four kind of stages. So it might be a very, very early stage digital app or algorithm, for example. The request comes in, one of the team will sit down for an hour with the team that's made the submission and say, actually, your product looks as though what you're trying to do is this. Well, here's basically the journey that you would take through development through to adoption. Here are the different regulatory barriers. Here are the kind of things you need to think about. Here are some sources of further advice. So that's kind of basic offer, and everyone gets that. Yeah. And then that goes through stages 2, 3, and 4. If it's something which either looks particularly promising, is at a particular stage of development, or is in some of the really key priority areas for the NHS, then they get more tailored support. And then at the sort of extreme end of this, there are companies whom we've worked with actually we started working with before my time here, which is 7 years ago. Gosh. And we are still working with, as they have gone through real-world evaluation, first adoption in the NHS, first overseas sale, wider adoption into the NHS, and several funding rounds. Gosh. And there's about 10 of those that we're particularly proud of our role in their successful journey.
So what's I'm interested in what the motivation is for HIE to sort of stay with them that long? Is it just a belief in the product? Is it, the £41 million that you've unlocked for the UK economy we should talk about, but I'm just interested to what is it that drives that length of engagement? Is it just because of the value of what they're producing?
It's the value of the product or solution or whatever it is that they've developed, their early success in, I was going to say in getting it adopted into the NHS, but it's even before that. It's the understanding of the kind of real-world evidence or real-world evaluation that they need, because not everyone gets that, and we can talk about that in more detail. And I guess also the quality of leadership and the type of leader that they have. Many of these are clinicians, often actually quite early or mid-career clinicians, so not people who've been consultants for 20 years. Yeah. Certainly qualified doctors, and it's probably in the 5 to 10 years after they qualify as doctors, so after they finish med school, possibly getting into consultant level, possibly into being GPs, but still relatively early to mid-career, who have seen a gap in the provision for something, or seen a particular condition for which there is a clunky or no adequate solution, whether it's a test or generally a test or a piece of technology, and have had the extraordinary both drive, entrepreneurship, sort of motivation through values that they want to care for patients and the public with this condition, to say, right, I'm going to change it, I'm going to develop something.
No, it's quite interesting. We had Dr. Hugo Ford and Shelley Thake on talking about the new Cambridge Cancer Research Hospital, and that's been a really popular episode, rightly so, because of their insight. And what I think is fascinating from your point of view, you're going to have all those flaws of specific cancer research, and that was going to keep you, one hopes, quite busy in terms of drug discovery, new findings, new things that could come out of there that could make a huge difference to patients from all over the world, not just here in the east of England or in Cambridge, in terms of treatment, in terms of making the disease more manageable, and so on and so forth, and not to be glib about it, but no, that must be quite an exciting thing. So let's talk about that economic value you're unlocking, alongside perhaps also your work as a paid for consulting. Because I read that and I thought, well, that sounds an entirely sensible thing to do. I mean, is that something that you specifically granted the freedom to explore, or is it something that the Health Innovation Networks have said, let us do this because we can add value?
Yeah, let's take that into the two pieces. So about the economic growth, the Health Innovation Network, and I perhaps should have said at the beginning, we're part of the Health Innovation Network, which is 15 organisations similar to ours that together cover the whole of England. Because as we talked about, change management being a human contact sport, it only works through trusted relationships. Yeah, and it wouldn't work if we were a sort of national head office sending people out around the country, and we've got to have these local relationships. And the sort of principle on which our network was founded was the equivalence of health and wealth. Now, people like Michael Marmot often talk about the people in poorest health are those from the most deprived backgrounds, because actually it's housing and education and those kind of food and those kind of things which often have an impact on your health. But equally, and this is actually quite pertinent because the government's new industrial strategy came out on Friday, a couple of days before we're talking, that health, life sciences is one of the 8 designated sectors by the government for investment, special treatment, however you describe it. This government, quite rightly, is all about growth. That's their guiding principle. And therefore health in the sense of life sciences discovery, world-leading life sciences products and technologies and medicines, which we still have in the UK, are an important component of increasing both the nation's wealth, and of course if people are more healthier, they tend to be more economically active, and therefore ultimately contributes to their wealth. There's this whole kind of equivalence.
Yes, indeed.
In a paper called Health and Wealth, which I think came out in 2011 or 2012, something like that. So to prove that side of our work, at the end of every financial year, we survey the hundreds of companies that we work with during the year, so both at Health Innovation East and in our national network, and we ask them a couple of questions. We say, have you been able to raise capital or increase sales this year at least partly as a result of our support? And have you been able to either recruit or safeguard jobs, again, as a result of your support, of our support? We get quite a good return rate, and so the £41 million figure that you refer to is the number that the companies we worked with, or those who have responded, replied, and we added it up. And so the work that we've done with companies in the east of England has helped them to leverage, raise, however you like, £41 million of investment, which on any Treasury Green Book metric or otherwise is a pretty good rate of return on the relatively modest funding that we get.
And potentially just the tip of the proverbial iceberg, because that's just based on the people who answered the survey, not the entirety of your
return rate. And obviously we have to, we always have to chase people to respond to a survey. But we're really proud. That's their own numbers. That's not our estimate. This is actually what those companies have told us. So that's a good statistic. So that's the kind of health, wealth, economic growth side of things. I'm often slightly jealous, and this is not really straight into politics, but our opposite numbers in places like Manchester, Newcastle, South Yorkshire are often able to tap into specific regional development funds. So Manchester has had a lot of specific life sciences funding for deals. Cambridge has had those. The east of England as a whole has had fewer.
I think
that's another aspect of economic growth, which certainly our colleagues in the north have also been able to tap into.
Well, it is to be hoped, said he. It is to be hoped that once we get a combined county authority for Norfolk and Suffolk, and I'm particularly thinking you've got Martlesham with the health tech developments there. You've also got my very good friends at the Quadram Institute at the Norwich Research Park, and I don't want to miss anyone out, but I know there are a plethora of others. Stevenage, indeed.
Anglia Ruskin and Chelmsford and that sort of Essex corridor and Stansted.
But let's hope that as the East of England gets more combined authorities, because for a long time it's just been the mayor of the Cambridge Business Department,
which is a difficult position because he or she's also got the county council, the city council, and
So let's hope that can unlock a greater amount of the investment, and I think that would be a very sensible investment, certainly to judge by the return you've already got. So let's look at those paid for services, because again, that's an entirely sensible, wise way to go about it. And you sort of started talking about that, but that it's something that the organisations, the networks had been sort of keen to explore. Are you particularly well advanced in getting for the Eastern?
Well, this is partly my own background as management. And we have trebled our turnover and our headcount in my time here. So when I started in 2018, we were 25 people. We're now 84 or 85, something like that. And actually, headcount's quite a good measure of impact, because we're not here to make a profit, we're here to be sustainable. And I think that's an important distinction. Equally, we're not a charity, we don't have charitable status. So we are set up as a company limited by guarantee, so we're an independent legal entity. We're not, as some of the other networks are, a cost centre within the NHS. We're actually an independent legal entity. So as chief executive, I'm answerable to our board, and our board are, I'm also a member of the board, are the stewards of our company and its resources and its people in the legal way that your listeners will be familiar with. And there were two motivations for developing our services and our offer. One of which is we do interesting, impactful work. We like to do more of it because it'll benefit more people and more patients and more NHS organisations. And the other is, if you're largely funded, as we are, by the public sector, increases in funding often don't keep pace with inflation, particularly the high rates of inflation that we had sort of following the return of COVID and the start of the Ukraine war in 2022, 23, 24. So for both of those reasons, we thought it would be sensible to try to extend our offer in terms of its breadth and its depth, to see if we could offer paid-for services, building on and leveraging the people, the skills, the relationships that we've got.
Yeah.
And there are three areas where we've been particularly successful. One of which is in health data services. So we've been successful in applying for quite significant funding awards to build data infrastructure projects. So there's something called the Secure Data Environment in the East of England, which is again is part of a national programme where we are supporting Cambridge University Hospitals, Addenbrooke's, who are the SRO, the accountable body on this contract, to build a cloud-based data environment which will be able to ingest patient data from many of the hospitals across the East of England and hopefully in the end primary care data for the purposes of research. And because it's cloud-based, all the protocols have worked out, so you're not back in the old days when if somebody wanted patient data it would be sent on a DVD and this uses proper security protocols that accredited researchers can say, I want, for example, 2,000 patients with a particular combination of long-term conditions, with a particular phenotype, in a particular age range, whatever it is, because I want to be able to look for patterns within those. It might be around, one we did was patients readmitted within 30 days after an original admission for heart failure. So what are the similarities between those patients who have been readmitted within a relatively short amount of time after discharge? So the secure data environment can provide them with that without the data actually leaving the original space that it's in, which is the patient record. It kind of looks through, it runs the inquiries in the cloud, and then gives the outputs back to the researchers, and the data has never left its original place. So, yeah, it's a national programme, originally funded by HDR UK, but is now designated as a Treasury major project with from 2026 on funding from the Wellcome Foundation. So you can imagine that to conceptualise and build something like that, we've had to recruit a team of, I think there are over 20 now, data scientists, bioinformaticians, people like that, under the leadership of our Director of Health Informatics. So that's a project which we've done absolutely hand in hand with Cambridge University Hospitals, but partly because of our legal status, we've been able to move relatively quickly and recruit the team that's been needed to develop and build that.
So you've been put in that really nimble space where you're a bigger team, but you're not so big that you can't move. I try and change the phrase, move fast and make things. You've created some guys. I mean, just the fantastic possibility of what you can do with that data, and you can spot patterns very quickly, and one would imagine the advent of AI will speed that even further. I would imagine, I don't know, but you've got something that can make a real difference and radically reducing, one can see a radical reduction in the amount of time it takes to process that, which might take, your clinician ages sort of going through paper reports to work out, and yet brilliant. That's just brilliant. You could say, I want this many patients, and these are the comorbidities, and it'll just say, right, here you go.
Yeah. It's mentioned in the life sciences, in the industrial strategy, and will no doubt also be mentioned in the government's life sciences sector plan, which is coming out, I think, at the end of next week. Data is one of the UK's assets, so as I say, it was talked about in the overall industrial strategy, but for years government has been looking at how do we use, absolutely in the right way, securely, with patient consent and trust and all those kind of things. The unique data asset we have in the NHS is because we are the only health system in the world where everyone's data is within the same record, so the primary and secondary care record driven by the single NHS number. So if you live in France or in the US, you're part of a system, but you're not part of a national system like that. So we have 65, 68 million people, whatever our population is, each of whom is longitudinally identified through the single NHS number. So, typically you'll go onto the NHS app, which hopefully many of your listeners will be doing regularly. And you can see, certainly in primary care, the summary care record, which will show, or in some cases the full care record, which will show you all the notes from your GP consultations, the tests that you've had back. But increasingly, it's also able to show you things that have happened in secondary care, the hospital environment. And because of the NHS number, we're the only system in the world that can do that, and therefore that treasure trove, if you like, is uniquely valuable to life sciences companies, to researchers, to universities, etc. particularly when we're looking at things like the new GLP-1 obesity medicines, which are very topical at the moment. And the government successive governments have been thinking for a long time, how do we commercialise this data for the benefit of the country and for patients without selling it to one of the big California tech companies, for example, who would also be very interested in it, but that wouldn't be what people in this country would generally be happy with. And it's taken a while to work out, but with advances in cloud computing and data security, the secure data environments, there are 11 or 12 of these nationally, are a first look at how that data might be used for research purposes.
It's wonderful, and the amount of advances that can be quickened, it can be brought on stream faster because of that accessibility of that data is a really fantastic. And one of the three key shifts of the NHS we see is analog to digital, which is, you're thinking, surely it's digital already, but yes, and I think on that kind of almost hangs the other two, which is shifting from treatment towards prevention and hospital towards the community. Although it's one of those things we keep rediscovering that we should be in the community, we had these things called cottage hospitals many moons ago, which kind of all sort of slowly vanished. We're just sort of rediscovering the need for them. I don't know why I'm talking about this, but anyway. So I guess it must be really wonderful for you, and you're in a position that not many of your colleagues across the networks are, when you say, well, you've got Cambridge on the wider, you've not just got AstraZeneca on your patch, you've also got GSK at Stevenage, and the whole ecosystem over such a broad area, where I would imagine that only a very few of the other networks, perhaps London and whichever one covers Oxford, would say the same.
So there's three in London. So there's UCL Partners, Imperial, and South London, which covers Guy's and King's. So those are all absolute powerhouses of medical research and innovation. There's Oxford and Thames Valley, and increasingly Health Innovation Manchester. Manchester is in a unique position because of DVMANC. And the control that they have, that the city has over its NHS institutions, and even more so because of the Greater Manchester Shared Care Record, where everyone's primary and secondary care data have for some years been housed within the same patient record. And there was a pioneering study 10 years ago called the Salford Lung Study, which uses data. Okay, brilliant. So you'll know all about it. So increasingly that's given them an advantage because they've been able to use data in a particular way. So, but equally, some of the things we do touch everyone's lives. It's not just about the very early stage biomedical research, of which Cambridge is particularly famous, but it's about innovations that actually get into people's lives and make them better. So what we tell ourselves pretty much every day, it's fabulous being in Cambridge, and we're having this conversation in our office, which is less than a mile down the road from Adam Brooks Hospital. Mm-hmm. But also we do have some significant economic deprivation and health deprivation in the east of England. So we have, there are parts of coastal Suffolk, for example, as people will know, coastal Norfolk, parts of Essex, particularly the sort of more out of London bits, where deprivation, by whatever kind of indicators you measure it, is among the worst in the country. And we've got a population of 7 million that has this very wide spread between people in, around our office who are pretty well off in this part of Cambridge, and people who are in among the most deprived wards in the country. Yes. So we remember that, and a lot of the work that we do, you can see on our website, is about reducing health inequalities. And if we have the choice of doing a pilot project or a kind of first real world implementation test, we try to do it somewhere where there is a disproportionate patient benefit. So it might be in coastal Norfolk, for example, but just sort of doing it in GP practice around our office, because the health gap there is lower than it might be.
You're not necessarily going to get the results you need to show you.
Well, it's about who's it benefiting. Exactly. You want to benefit the people who, who has access to trials. Everyone, most people who come into Adam Brooks Hospital will get the chance to get on a trial. That's not necessarily the case in some of our more far-flung hospitals. So recognising, the work of people like Michael Marmot and Bola Olabi at NHS England. It's really, really important that all communities have a voice in this and have a chance to participate.
And on that note, just to close with, what can the rest of the East of England, particularly in the academic and research space, do to assist you in your mission, in your collective mission for our healthcare?
Well, we're really privileged to be in the East of England, and particularly to be in Cambridge. We have a great response rate from the companies we work with. We've got really well-developed relationships that we've had over the last 7 years. I suppose the thing really to bear in mind all the time is, as a health innovation network, we've developed a little slide called the 7 Successful Habits of Innovation.
Right.
And it's kind of like a wheel. You can see it, I think it's on the network's website. The first of these is the most important, and it's think pathway, not product. And it's what we were saying earlier, inventing the product or the medicine or whatever it is only the first. It's an incredible step, but it's only the first step of getting this discovery into patients and into care settings, because of all the complex implementation that we talked about. So the clinical pathway, which is the journey that a patient goes through from presentation through to diagnosis and treatment, and how the discovery that we're working with interacts with and facilitates that. So think pathway, not product, is probably the one single thing that I might single out there.
Well, Piers Ricketts, it's been an absolute pleasure to talk to you this morning. Thank you very much for your time, and I know that the listeners are going to find this fascinating, so thank you very much for that.
It's been an absolute pleasure. Thank you very much too.
My huge thanks to Piers and the Health Innovation East team for their help in setting up this interview. I look forward to keeping you informed about how Piers and his team and the wider health innovation ecosystem in the East of England rise to the challenge. And that's all there is for episode 142 of the Eastern Promise podcast. I have been Mike Rigby, and will be so again next week, when I will be heading to the home of plant and microbial science in the UK, the John Innes Centre. Direct from Norwich Research Park, we'll be delving deep into the secrets of this world-feeding, world-healing academic research centre. And our guide will be Dr. Penny Hundleby, known to you all as my co-host on our Royal Norfolk Show specials. That's here, all here, in 7 teeny tiny little days. Surely, not long to wait. So until then, bye for now. To hear other episodes of the Eastern Promise podcast, and to find out more about what we do, go to our website at easternpromise.org.uk. Eastern Promise is a Pudding Shed production in proud association with Mills and Reeve. Achieving more together.